So this is the presentation on integrating mental health into primary care and school settings. I have to offer a special thank you to Dr. Bernadette Melnick and Lee Small, from whom I have adapted this presentation. Much of this original work was developed for Dr. Melnick's KISS campaign for NAP-NAP. I want to start with a definition of mental health and talk about what we mean by that. And to have a healthy mental state or good mental health, it means that we can successfully perform our mental functions that result in productive activities that fulfill relationships with others, and our ability to adapt to change and to cope successfully with adversity. And this particular definition was developed by former Surgeon General Satcher in 2003. When we talk about the incidence and background of mental health issues in children, we want to just keep in mind that some data suggest 1 of 4 kids in the U.S. have a mental health or psychosocial problem that results in some morbidities that impair their ability to function either at home or school or both. And keep in mind that suicide is the 3rd leading cause of death in the 15 to 24-year-old population nationally, second or 3rd only to motor vehicle accidents and homicides. In Colorado, it's actually number 2 after motor vehicle accidents. There are 1 to 2 9 to 17-year-olds with serious emotional problems in every U.S. classroom, and mental health and psychosocial morbidities are becoming more common than physical health problems in children and youth. And so when you're seeing these kids for a sports physical or their annual well child visit, keep that in mind, that the chances of you finding a mental health issue are equal to, if not more prevalent than, the physical findings being abnormal. And Children's Mental Health Week 2017 wanted to really make the public aware that 1 in 4 children show evidence of a diagnosable mental health problem. So just a few more facts for us to ponder before we get into what are we going to do about this. Mental health problems are underestimated due to inadequate screening, intervention, and referral by primary care providers. We know that about 70% of youth in need of treatment don't receive mental health services, and there is a drastic shortage of mental health care providers, with an estimate of 6,300 psychiatrists in the United States and a need for 30,000. So frequently the primary care provider is the only person who's available to help this family, and we know that PCPs accurately identify mental health problems around 1/3 of the time. The range is 16 to 38% of the time. We also know that over 12,000 children were placed in the child welfare or juvenile justice system in 2002 in order to receive mental health services. And that's sort of a sorry state of affairs. If you determine a child really needs mental health services, why do they have to be placed? We also know that African Americans are far more likely to have a mental health disorder than whites and are less likely to seek treatment. We know there are astronomical costs associated with mental health illness in the United States, and it's estimated about $69 billion per year. is spent with 12.6 million being allocated to substance abuse treatment above that 69 billion, sorry. And despite the prevention and intervention efforts, many of these problems continue to escalate. We know that children are most likely to receive mental health care in primary care practices and schools. So providers need to be competent in screening and early intervention and then referral to specialists if that's not successful. So let's talk about what are some of the risk factors that you will see in these children who may have mental health issues or behavioral health issues. Poor self-esteem is common, lack of the developmental assets, which I'm going to say more about here in a minute, but both internal and external assets that help a child cope with the challenges that come into their life. Altered parenting, so overprotective and controlling, rigid, or very permissive with lack of supervision have all been associated with these mental health and behavioral problems. Conflict in the family, separation and divorce, parental mental health problems, including substance use, chronic illnesses or a handicap. We know those children are more likely to be bullied and suffer from low self-esteem and depression and anxiety. Frequent hospitalizations or life-threatening medical procedures, learning disabilities, poor grades can be a red flag, and also multiple stressors or recent stressful life events. Additional risk factors are behavior problems, and sometimes that's the first thing that you will notice with children. Stressful home or school environment. We know our LGBT population is higher risk. Any child with a history of substance use, peers who are engaging in risk-taking behavior, children who isolate or who are being bullied, or traumatic events or difficult temperament can all be risk factors. There are also protective factors, and the protective factors that have been identified can be categorized into these two categories, the internal and external assets, which I'll talk about here on the next slide. And they include some of the bullets that we have here. We know that children are protected if they have a connectedness to a parent or a positive adult role model. Children who have more resilient nature about them, they just kind of roll with things. Kids with healthy coping skills. Authoritative parenting, which are, it combines the love and consistent limits and some monitoring of behaviors. Involvement in sports or other extracurricular activities can be protective. Having responsibility and accountability can be protective. A supportive community is considered to be one of those external assets. A supportive home environment, a positive school environment, positive peer group. Refusal and assertiveness skills, they know how to say no and walk away. Spirituality, a sense of purpose, and experience some success in a variety of things, including academics. So the Search Institute has published a series of studies that have looked at correlations between children who are more resilient and those who are less resilient. And they've identified these 40 developmental assets, which are associated with children being more resilient. And the external assets are things that include support from family, positive family communication, other adult relationships, a caring neighborhood or school climate, or parent involvement in the school. The second major category for the external assets is empowerment, and that is community that values youth and young people and protects them, has some adults in the community that value youth. Youth are viewed as a resource in that community, and they provide services to other young people, and they're safe. The other major category is boundaries and expectations, and that includes family boundaries, school boundaries, neighborhood boundaries, some positive adult role models, some positive peer influence, and the high expectations from both parents and teachers can be really influential in the child's resilience. And then the final category in the external assets is constructive use of time. And that's involvement in creative activities, youth programs, religious community, or time at home with parents for some good role modeling. Then the next major category is the internal assets, and it also has 4 major categories underneath the internal assets. And that's a commitment to learning. Kids who have experienced some successful achievement in school or home or work, school engagement, kids who are successful with their homework and get their homework done, have a commitment to it, if they have bonding to the school. And we know that also reading for pleasure is linked to resilience in kids. The next major category for internal assets is the positive values. And that is a caring young person that places high values on helping other people, kids who care about equality and social justice, kids with integrity, and kids who are honest and responsible and show restraint. So those are positive values in the youth themselves that are linked with resilience. And then the next major category in the internal assets is social competencies. So planning and decision making, young people knows how to plan ahead and make choices. Interpersonal competence, they get along well with others and they have some good communication skills, they're empathetic and sensitive. Cultural competence is another aspect of this, and the kid has knowledge of and comfort with people from different cultures, racial groups, and ethnic backgrounds. Resistance skills, which we've mentioned, the ability to say no and walk away, and peaceful conflict resolution skills are another part of this social competence. And then the final internal asset category is a positive identity. And that involves this personal power where the kid feels he or she has a control over things that happen to them. They have self-esteem and a sense of purpose, and they have a positive view of their potential future. So you can read more about these internal and external assets from the Search Institute website that is included on the slide. So what's our general approach to mental health screening in primary care going to look like? The first thing you want to do is ensure the family, whether it's the parent you're talking to or in the case of adolescents, the adolescent, that this is all confidential and won't be shared with anyone unless someone has hurt the child and or the child wants to hurt himself or someone else. And you want to screen for common mental health disorders at every well child visit, and this includes sports physicals. It identifies the current problems, identifies those with the risks of developing mental, emotional, or behavioral problems, and uses validated screening tools that can be completed in the waiting room or emailed or texted to the clients prior to their office visit. So let's talk about what some of these tools are. One that's been accepted in our practice in Sheridan is the Pediatric Symptom Checklist, and it's a 35-item checklist that includes both internalizing and externalizing behaviors. It was developed for kids between the ages of 4 and 16 years. There are actually two forms, the parent report form for the younger child, or there is an adolescent form that they can complete themselves. And it usually can be administered in about 5 minutes if literacy is not an issue, and you can score it in 2 to 3 minutes. It has very robust sensitivity of 91%, and the specificity is 65%. So we know it picks up problems really well. Usually have to do further evaluation to identify specifically what problem is this child experiencing. The Child Behavior Checklist is another tool that can be used, and if a significant score on the PSC is found, parents should complete the CBCL. And it's used to assess kids in that 4 to 18-year-old group for both competencies and behavior or emotional problems. And parents respond on 118 items of not true to somewhat true to very true, or often true. And the scoring takes about 10 minutes. And this link will take you to that website to order those. It's also important to get the parent's evaluation of the developmental status, and there are a couple of validated instruments that you can use for that. The first one that I'm going to talk about is called the PEDS, and we have talked some about development in this course earlier, but the PEDS is a parent report screening tool that has 10 items that asks the parents their concerns about development, cognitive and behavioral problems from birth through age 8. And the sensitivity ranges from 74 to 79%, and the specificity is around 70 to 80% across age levels. It's available in English and Spanish, and it takes about 2 minutes to complete. And it's available from the website listed here. The ages and stages, which many practices in Colorado are using, and you are familiar with it from a prior assignment in this course, is also a validated instrument to assess child development. And it's for kids up to 60 months or 5 years. And it's parent report, it's available in English and Spanish, and the scoring also takes 2 to 5 minutes. Some other resources that are available for assessment are the Guidelines for Adolescent Prevention Services, the GAPS, and it was actually developed by the AMA in the 90s. It's a series of questionnaires to support the implementation of the Guidelines for Adolescent Services in primary care, and it screens for a wide variety of teen problems. There are child completion forms and parent report forms for both early, middle, and late adolescence. They're available in English and Spanish, and they're available on the website listed here. More recently, the GAPS has been adapted to a shorter form, and the RAPS is available, and that is, if you've done clinical in our faculty practice sites, you have seen the RAPS being administered. Another resource that's available to you through NAPNAP, the National Association of Pediatric Nurse Practitioners, is the KISS campaign, the Keeping Yourself and Your Children Safe and Secure. And they developed a survey in early 2000 that really was for children and youth aged 10 to 20 years to assess mental health knowledge, attitudes, worries, communication, and need. It's written at the 5th grade level. It has 60 knowledge and attitude items and 13 items about common mental health problems. It also asks questions about the parent and child communication, the child and provider communication, and satisfaction with the provider. And it also has some reliability and validity established for that tool. It's another item that can be used if you sense there are some unresolved issues in this family and you just want another source of information. The HEADS is an acronym that represents the following assessment. So home, is it a supportive home? Is there a lot of conflict, chaotic, or dysfunctional? The where is the kid living? Who is in the home? How do they get along with people in the home? Have they ever run away or been incarcerated? Those are specific questions you can ask around the home. For education, ask how is school? How are their grades? How are the teachers? What are their peer relationships like? Have they been suspended or missed school? And the activities and peers are extracurricular and sports activities. What do they do when they hang out with friends? The D is for drugs and alcohol. So what drugs have they done? And in the younger adolescents, I think asking, have you ever had any friends who have done any drugs is a better way to get information. Have they tried cigarettes? How much caffeine do they use? Talking about drug use in the family and friends can be also very enlightening. The S stands for sexuality and suicidality. And so you want to ask if they're sexually active, their sexual preferences, contraceptive use, number of partners. Have they ever had a sexually transmitted infection? Do they use condoms or any other contraceptive use? And have they ever had a history of pregnancy or abortion or any history of sexual abuse? And then for suicide, you want to ask any suicide ideations, any past history of suicidal attempts, and do they currently have a plan? And then some people, in addition to the heads, add the ED, and the E is for emotions, behaviors, thought disturbances, and we're going to talk more about that here in a minute. And then if a child is hospitalized or in treatment for any reason, you also want to know what discharge resources, or even if you've made a referral, how long is the wait list, and when will they get help, and what's the interim plan? So a critical question for the parent interview is, do you have any concerns or worries about your child's mental, emotional health, or his or her behavior? Or has there been a change in how he or she usually is at home or at school? And if yes, then you're going to follow up with a more comprehensive evaluation with the following questions. So what's the history or the background of this concern? It's important to obtain specific information about the concerns with the following questions. So what specifically has happened or has changed? What is the concern? What precipitated it? Are there associated symptoms, whether they're behavioral or they're physical or they're symptomatic? Where does it happen? Is it at home, at school, at daycare? When does it happen? Is it during a transition? Is it right before school that they have a stomach ache? Who is with the child and who's involved when it occurs? How does the parent deal with it? And how does the child respond to that? And why do they think it's occurring? Does the parent know why, or does the child know why? We also want to ask the parent to name 3 words that describe their child. And this can be very enlightening. If they cannot come up with anything positive to say about this child, that's a red flag for you that you need to refer this family for some behavioral counseling. Because if the parent is that distraught and can't come up with anything positive to say about the child, that's worrisome. You also want to say on a scale from 0 to 10, what is your child's self-esteem, with 0 being very poor and 10 being great. And then ask, what do you see as your child's strengths, self-esteem, coping skills, school, athletics, whatever. What risk factors for emotional or behavioral problems does your child have? Do they have friends? Do they have trouble expressing feelings? Do they fight with their siblings? And then, has there been any recent change or stressor in the family? Is there a separation, birth of a sibling, an illness, or a death of a family member? And how is your child's attention span? Can they concentrate on performing an activity and follow it through to completion? And a good rule of thumb developmentally is they should have attention span of 1 minute per year of age. So if we're talking about a 5-year-old, they can't sit there for 20 minutes and focus on an activity. That's just not realistic. So a few more questions for the parent interview that we can consider. Does your child have any behaviors that worry you? Anger outbursts or temper tantrums, aggression, antisocial behavior? Any substance use should also be a concern. How would you describe your child's personality and temperament? So are they optimistic or pessimistic, difficult versus easygoing, loud versus quiet? How would you describe your child's usual mood, depressed, happy, anxious? How much does your child worry about things, school grades, what they look like, what others think of them? And what do they worry about? And as far as you know, has your child ever hurt himself or thought about hurting himself or herself? Has your child ever physically hurt anyone or been involved in a physical fight? How does your child cope with stress or handle frustration? Does your child complain of headaches or stomach aches? If yes, how often, and does it interfere with daily activities or miss school? How are things at school? Their grades, how many days are they absent? Do they have friends? How do the teachers respond to the kid? How does the kid sleep? What time do they go to bed? What time do they get up? Do they sleep through the night? Do they have nightmares? How does your child get along with others, and how many close friends does the child have? Is your child ever teased or bullied? Are there differences in how your child functions across setting? Is a kid relaxed and carefree at home and stressed out at school? And then, to your knowledge, has your child ever been physically or sexually abused? Has your child had a frightening or traumatic event, exposure to violence or a motor vehicle accident or hospitalization, surgery, something like that? Has your child ever been seen for a mental health or behavioral problem? And if so, for what? How long? What was it helpful? What did they get? Has your child ever been on medication for one of these problems? What medicine, for how long, and did it help? Were there side effects? When was it discontinued and why? As far as you know, has the child witnessed any violence or watched a lot of arguing or conflict? And does your child watch TV or play games with violent or sexual content? So just a few more interview questions, and then we'll move on to the rest of the exam and referral. Has your child suffered losses, the death of a parent? We talked about hospitalizations, motor vehicle accident. As far as you know, has your child ever, or does he now, use alcohol, drugs, laxatives, caffeine, stimulants, some pain meds in the house? Does your child have a learning disorder, or do you think he may have a learning disorder? And may I obtain information from other people who are involved with your child, teachers, daycare providers, grandparents, if it's a divorced family, the other parent, just to get more information about your concerns and help me treat him or her. Parents should sign a release form for each collateral source of information. So now we're going to ask about the family medical history, and we want to really be specific about any psychopathology. So does anyone in the family have a mental health disorder like depression, suicide, anxiety, bipolar, substance use, or learning problems? If yes, who is it? What type of disorder, including what treatment, medications, behavioral counseling? How stressed do you feel on a day-to-day basis? How depressed do you feel on a day-to-day basis? And describe the family functioning. Is it effective or ineffective communication among the family members? Is it supportive or non-supportive? Is the home environment in general happy, sad, tense, peaceful, conflictual? And what's your parenting style, and has there ever been any history of abuse for either of the parents? Do you ever feel frustrated to the point that you may hit or hurt your child? What type of parenting style do you have? And really sort out if it's authoritative, permissive, or authoritarian with those additional questions listed there. What beliefs do you have about how parents should discipline their children? Are you consistent? Do you know what to expect of your child? And what's the easiest thing about parenting your child? What is the hardest thing about parenting your child? How well do you believe you are connected emotionally with your child? If the history, both of this child and the past medical history and the family history, indicate some potential areas of concern, for example, learning disorder or some psychopathology, then you're going to follow up with other testing. So psychological testing may be required if the child's had traumatic events. Educational testing may be required if you're thinking a learning disorder. Neuropsychological testing, if there's any positive screening around oppositional defiant or ADHD or any other bipolar, any other concern that you have from the screening questionnaire should be followed up with a specific test to diagnose. And then input from multiple sources is needed. The medical screening focuses on ruling out any medical health condition that could be the cause of the behavior. So obtain a general health history, including the review of systems, the past medical history, including the development, medication history, complete physical examination. And you want to really be tuned in and thinking about ruling out vision and hearing problems, anemia, hypothyroidism. Mono can cause the chronic fatigue, and kids can just be exhausted, and that's interpreted as depression. Likewise, lupus can cause that decreased energy, and so that needs to be taken into consideration. Developmental delays can play into this, failure to thrive. Screen, especially adolescents, around eating disorders, substance use. PMS is common to cause the altered mood shifts in our adolescent girls. So that's also, the timing. Is this depression or moodiness around your menstrual cycle? That's an important question. Diabetes mellitus, head trauma can cause behavior changes. Any CNS lesion can cause behavior changes, seizures, Cushing's syndrome, HIV and AIDS, and mitral valve prolapse can also cause the fatigue. You also want to conduct a mental status exam, and as we look at this diagram, it sort of spells out for you. Think about the appearance and behavior. So are they neglecting self-care? Do they have either a flat affect or a sad kind of furrowed brow and a frown? Look at their rate of blinking. They have a decreased rate of blinking if they are feeling depressed. And look for any abnormal gestures or decreased eye contact. Speech could be slow with long pauses or very loud and quick. Little spontaneous speech where you have to pull it out of them. And then look for mood and affect. With a low mood, they can be particularly bad in the mornings. They're pessimistic about everything, hopeless. They have guilt about the past. You definitely want to ask about suicidality, and again, pay attention to the affect. You want to also assess their thought. Do they have any delusions or any, certainly if they're having any thoughts that they're being treated unfairly or persecuted, those are important things. Their perception, are they having hallucinations? Not terribly common in younger children, but can happen in the older adolescents. Cognition you want to assess. Are they oriented to time and place? What's their attention span like? Can they remember things? And then do they have insight? They may not be aware of the mental illness, but they think they have all these somatic complaints, and they want you to do something to take away the headache and the stomach ache and the tingling of their arm and all the somatic things that they may come up with. So you also want to really evaluate the thought processes. Are they coherent? Are they disorganized? Is there a flight of ideas where they skip from topic to topic, or some blocking? They can't remember what happened at the fight at school, or loosening associations where they shift topics quickly to unrelated things. Echolalia, which is a repetitive repeating of another person's words, or perseveration where they are just obsessed about one particular thing. You also want to, as we mentioned, evaluate the cognitive functioning, and you're going to pay attention to their attention span and their ability to do abstract thinking. Make observations of the parent-child interaction and document that. And if further testing is warranted from the history and the physical exam, you're going to refer to a mental health specialist. So here's an example of a write-up of mental status assessment. Shannon is a well-groomed, healthy-appearing, overweight adolescent who is cooperative and pleasant in her conversation. She sits calmly without abnormal movements and makes good eye contact. Her rate and quality of speech are normal. Her thought processes are generally well organized without delusions. Shannon states that she can go quickly from a 0 to 10 in terms of her anger. It is evident that she has a pattern of depressive cognitive thinking as she degrades herself frequently. On a scale of 0 to 10, Shannon rates her depression as a 4 to 5 on average, and talks about the fact that she sometimes worries, especially about how other people view her. She denies hallucinations or any sleep problems. Shannon states she needs help with anger management. She has poor impulse control, as evidenced by frequent anger outbursts in her home. Shannon denies suicidal or homicidal ideations. She has some insight into her problems and talks about her desire to be a landscape designer. Short and long-term memory are intact. So, based on your assessment of the child, then, you are going to decide, do I want to intervene? And a lot of times with the younger kids, the interventions are parent-focused. For school-age and teens, they can be skill-oriented. Or do you think you need to consult with a mental health professional, or is it very clear from your assessment that they need referral? And in addition to that, you want to support communication with the child and family. So you want to consider the severity, the persistence, and the resistance to change as you make your plan for this family. So some types of intervention that can be used. Psychoeducational is informing parents and children or teens about what to expect with the condition. Psychosocial interventions are more behavioral, and the cognitive behavioral skill therapy has the most evidence to support that it works for mood, anxiety, and behavioral disorders, and also works well in conjunction with medication, the behavioral interventions in medication for ADHD. And then the coping skills training and depression courses are also evidence-based and can be used by downloading from this website. So for medications, the psychopharmacology is limited on medications for children, and we need to be careful. We do have a few drugs at our disposal that can be used for children and adolescents, stimulant medication for ADHD, SSRIs for obsessive compulsive disorder, and moderate to severe major depressive disorder. And then risperidone also has been empirically supported as effective treatment for autism. I would encourage you to either get additional training on psychopharmacology or work with a psych NP or a psychiatrist to provide the medications, and then you can do the monitoring. But I believe that we need some additional training to actually prescribe and monitor these meds in children. There are, in addition, some resources that are kept up to date on guidelines.gov, and the website is there for you, and you can actually search in that box in the red area that I have highlighted for you. And you know, if you want depression treatment for adolescents, or you want depression screening for the school-age child, this is a great source of information and up-to-date guidelines for the clinician. And I hope you have a good time taking care of these children and families. It's critically important that we assess, intervene, and refer when needed.